quarterly updates. This is the last one for February for the winter of 2023. I am Chad Erdman. I am the Regional Resource Specialist for Regions 1, 2, and 4. So the upper northwest portion of the state. My office is located in Crookston, Minnesota. So if you know where that is, I'm way up here. Just a few things to cover before we get started. Everyone's been muted to reduce potential background noise, which I have to mute my phone here. We encourage you to use the call me option because this helps with the audio connection. And to ask a question, please use the Q&A panel on the right of your screen. We'll address questions as they come. However, if there's no response, we'll need to take it back for further consultation. So, also a reminder that this webinar is being recorded and the details will be posted on the training archive page when they are available. So, as Emily Miller, one of the other RS, usually does, they usually starts out with a joke. So to one up Emily, I'm going to actually going to give you two jokes. One is I had prepared kind of for Valentine's Day, and the other one is more so for St. Patrick's Day. So if these jokes are bad, blame Emily. All right. So what did the chef give his wife on Valentine's Day? He gave her a hug and a quiche. Yep, that's an Emily joke for sure. And my joke is, why is it a bad idea to iron a 4-leaf clover? Because you shouldn't press your luck. I know I don't do it as well as Emily, but that's just the way it bounces. So, but welcome anyway. If you could go to the next screen, Kyle, thank you. Here's our agenda for February. We're going to, we have a full session including DD certification of disability, customized living services, DHS announcements, COVID-19 updates. We'll review some upcoming training sessions and webinars, and we'll also do resources. So at this time, I'd like to introduce Amy Peterson with the State Medical Review Team. She's here to review information on the DD waiver as in regards to SMRT. So it's all yours, Amy.
All right, thank you, Chad. So I am Amy Pearson. I am the Appeals and Policy Lead for the State Medical Review Team. With me today also is Carly Pedersen, our SMRT Manager. Next slide, please. All right, so I'm here today to talk about the DD waivers. So an issue came up back in 2019 that was looked into. So one thing that had been discovered is that, well, actually, we'll talk about what the waivers are here first. So all people who request a home and community-based waivered service must be determined under the blind, aged, or disabled basis of disability or basis of eligibility in order to receive home and community-based services, waiver services. It's been Minnesota's longstanding practice to allow people specifically requesting DD waiver services to meet only level of care requirements as determined by MnChoice's assessments or county assessor. So an issue came up back in 2019. There was a bit of a disconnect. So county caseworkers believed that the home and community-based services manual required a disability of certification through Social Security or through SMRT for DD waiver eligibility, while the eligibility policy manual specifically stated that one was not required. So this was looked into. Next slide, please. All right, so all 1915C waivers are limited to certain eligibility populations, and individuals must be eligible for MA with ABD status in order to receive home and community-based services under the waiver authority. So although it may have been Minnesota's intention to lessen the assessment burden on clients and caseworkers by allowing the use of developmental disability assessments in place of a certification of disability from SSA or SMRT, there is no legal or statutory basis to do so. So all people who are applying for the DD waiver or need those services do need to have a disability of determination by SSA or SMRT. So if they do not already have a disability determination from SSA or SMRT, they must receive a determination in order to be eligible for the MA disability basis. Next slide, please. So we ran some data and we found that more than 24,000 Minnesotans are currently open on a DD waiver. Initial data that we've reviewed estimate that more than 3,600 of these clients do not have a disability determination. So thankfully, most of these people have already had a certification of disability by Social Security, and that was running data off of the Maxis UNIAD panel. We also found that about 1,600 of these clients had already been reviewed by SMRT. And so there are around 2,000 clients who do not have a disability determination by either SMRT or by SSA. We're currently working with SMI to confirm this information and get this narrowed down more. So what we've identified is roughly around 2,000 clients currently open on a DD waiver who are going to need a review done by SMRT. Next slide, please. So what the plan is going forward is we are going to start referring these folks to ourselves. We're going to identify them and we're going to do referrals into our system. So we're not going to dump all 2,000 referrals into our system at one time. We're going to start, based on their months of application, and we're going to go through the list and we're going to start sending out referrals or putting referrals into our system for these individuals very shortly. So we'll do the referrals into our ISDS system and complete disability reviews. A lot of information we can access already for these cases based on systems we have access to. So some might not need a lot of work. If we do need additional information, we'll send out worksheets and authorization forms like we do for all of our other clients. We'll also be contacting the county financial worker, faxing them a notice that the case is under review, and we'll be getting in touch with folks who work with them to help develop the case as well. If the individual does meet disability criteria, we'll issue a certification, update the DISA panel with the start and end dates, and notify the client and county and tribal financial worker. If the individual does not meet disability criteria, we'll issue a denial and contact the county financial worker and the client as well. Next slide, please. This is some of the communication we've done so far. We've reviewed with the Healthcare Advisory Committee. We attended Healthcare Eligibility and Leadership PIC sessions. We've done, I think, 2 of those. A SIR announcement was posted, and on January 27th, a follow-up announcement with some clarification was also sent on February 1st. The OneSource training materials have been updated and will be posted tomorrow as well. Next slide, please. Oh, that was it. I will say too, for all new DD waiver referrals effective March 1st, those ones will need to be submitted to SMRT if they have not already been certified disabled by Social Security. So any new DD waiver applicants as of March 1st will need to have a SMRT referral. All right, thank you.
All right, thank you, Amy. I don't see anything in the Q&A box. Oh, maybe I do. We do have a couple questions.
Sure.
For a SMRT denial, the case manager should be notified as financial does not know who that is, and there is no way for them to know any other way. That makes sense.
Well, for all of our decisions for any program types, that's how the counties are notified, as we fax a determination to the county financial worker. because they're the ones who are going to be opening or turning off the programs. So if there is a denial, a copy goes to the client. If they have an authorized representative on the case, a copy goes to them as well. But the standard practice we have is that the determination goes to the financial worker, and then however counties handle it from there is up to them.
Okay. Thanks, Amy. The next question is, how long do people have to get certified if they are already on the DD waiver?
Good question. So nobody is going to be getting turned off of a DD while we're doing our review. So it's not, we have to make a decision within a certain amount of time. These people have been on the waiver probably for many years for a lot of them. So while we're doing our review, or even before we do our review, everybody's staying on the waiver. The only time that the program would end is if we issue a denial on the case. So there's no set time frame for them or deadline.
The next question, Amy, is how long does the SMRT process typically take?
It varies. If we have information right away, like if we have IQ testing or we have forms that get in right away, it can be 30 to 60 days for a decision, sometimes sooner. It just depends on what information we might be waiting for. The longer it takes for people to send us back paperwork, that's usually the longest hangup that we have in developing cases is people that don't return their forms in a timely manner. So it's all I can really say is that it varies.
The next question is, when will lead agencies know of current clients who are not yet certified disabled? I heard Amy say SMRT was not going to do all the 2000 in February. Is there a timeline for the current population?
Really, it's going to be when we can get to them. We do about 7,000 disability determinations a year, and we have a staff of 19. So we're going to be getting to them as quickly as we can. It might be a slow process, but that's what we're looking at for now. There's really no set timeline.
Okay. And then you already covered this one, I believe. If someone is denied SMRT, what is the timeline exit from them for the programs? This is probably for somebody that's coming new.
Mm-hmm. Yeah, I don't know what the county does on that end, but what we do is the determinations of disability.
Okay. How long do SMRT reviews take? We are concerned in Hennepin County what people are who are Rule 185 case management and want to go to a DD waiver and timing out of the 60 days to get the waiver, to get on the waiver from the assessment.
Yeah, and again, the sooner we have information, the sooner we can make a determination. We do have an expedite process too, so if somebody meets our expedite criteria, we could take a look at those cases. There's just no set timeline, but the sooner we have information, the sooner we can make a decision.
How many staff are working on the SMRT reviews?
Yeah, so we have a staff of 19 right now, and it's going to be people all working together in our process. We're going to be referring them into our system. So, but yeah, our team right now is 19. We do have a proposal in legislature right now that we're waiting on. So asking for more staffing. So we're very hopeful that that goes through.
Yeah. Do you have to have an assessment before you can apply for SMRT?
Are you talking the Rule 185 or min choices?
It doesn't clarify.
Okay. So somebody doesn't have to have their min choices assessment done before they have a SMRT referral. They can be done simultaneously. We just want them to at least be scheduled if somebody is applying for the DD waiver. As far as the Rule 185, that's not really part of our process at all. What we look at is whether they're meeting the criteria for disability, but we do want them to have a min choices at least scheduled for us to review the case.
Okay. And I believe Melissa, Amy answered your question regarding the Rule 185. So try to keep up to the Q&A here.
That's a lot of questions.
It is, holy smokes. If the SMRT is refused, the DD waiver must close, right? Then they were not eligible for CADI either. Is the closure immediate or next assessment, reassessment time?
I can't answer that.
Okay.
Right now, we're still in the rules for extended eligibility after the ending of the PHE, so I don't know exactly how that's all going to work. What I can say is that, you know, we apply Social Security disability criteria. A lot of the folks on the DD have been on the benefit through having the Rule 185 done. The Social Security criteria for at least intellectual functioning is less stringent than what the Rule 185 criteria actually is too. So we don't anticipate that a lot of folks are going to end up getting denied going through the assessments. It's basically getting in line with statute and having that certification by SMRT or Social Security.
All right. The next question from Roxanne: why does a min choices assessment need to be rescheduled?
It's a long answer. This is some data that we have, but what we did is we went through a continuous improvement project back in 2019, where we looked at a bunch of cases that we certified. And again, we have a staff of 19. Each of our analysts can do about 500 decisions a year. And when we pulled data, we found that there were over 1,000 people that we had certified that didn't end up on a waiver. And over half of those never ended up on any programs at all. So this is kind of a fail-safe that we have for clients to make sure that they have these processes in place so that when we do all this work, gather this information, go through the time of making a decision, that person is going to end up on a program that they need.
And I believe this is the final question. So I am working on scheduling reassessments for April, and the first person I looked at is not Social Security Administration or SMRT disabled. I am to assume that the SMRT staff will be referring my client?
So if this person's already on a DD waiver, we will be getting to them at some point and doing a determination. If it's a new person, then if their assessment and everything isn't going to be done until after March 1st, then they will need a SMRT referral. Okay, yeah, if they're on a DD waiver, then we will be getting to them eventually.
And this is Corey. We just had a couple that were missed just because we had a lot coming in at the same time. So I'm going to go back to those ones. That one, was there information sent to the counties if someone in their county is one of the 2,000 people affected?
So what we're going to be doing is we're going to be doing all of the referrals for ourselves for these people that are on the DD waiver. We're going to be pulling them, looking at all of the systems that we can to see if they have the evidence we need, like psychological evaluation, IQ testing, things like that. If we're able to access that information and get what we need, then we can just issue a determination, a certification. If we need to get more information, we'll be faxing the county financial worker to let them know that we're going to be starting a review of the case. Sending paperwork out to the clients. If they have any AREPs or legal guardians, we'll be sending forms out to them as well. Getting in touch with the clients. If they have workers, we'll be getting in touch with them to help gather information to make these decisions.
Thank you. Next question that came in. This does not affect Rule 185 case management only. Is that correct?
Correct. Yep, this is only pertaining to DD waivers.
And the next question is, could you review the criteria of who meets The criteria to have their SMRT expedited. Can you review the expedited SMRT criteria?
Yeah, so if somebody's in a hospital awaiting discharge and they need to get assistance to programs through MA to be able to discharge, those are people that we can expedite. If somebody is in a life or death type of situation, you know, the really critical type of situation, or they need critical access to medical care, you know, those are expedite scenarios.
Thanks, Amy. I think that there is perhaps one more at the bottom here. So no county staff, such as the LTSS, economic assistance, DD staff needs to initiate referrals for existing waiver recipients. Is that correct?
Correct. Yep, that is
Thank you.
correct.
That's all the questions I'm seeing in the chat right now. I think that should be it. I'm not seeing anything else come in right now.
All right.
Okay.
Thank you.
Thanks, Amy.
Sure.
We'll move on to our next presenter, Stephen Horn, who is going to be covering some customized living service information. He's the waiver policy lead. So go ahead, Stephen.
Hi, Chad. Thank you. As Chad said, I'm waiver policy lead for customized living services in the disability services division. I work on the waiver policy and compliance team, and over the last like half year, maybe last full year, we've received some additional questions about service policies or increased volume on service policies related to customized living. And I would like to walk through several of those different our policies and how they interact with one another. Next slide, please. So the first part that I'll go through is describing the service. This will include the service scope and some of the service requirements. Reiterating the provider qualifications, and then walk through several different setting limitations that are specific to the brain injury and the CADI waiver programs. None of this is applying to the setting limitations do not apply to the elderly waiver. And then at the very end, there are resources specific to rate setting that have been developed over the last couple of years as well. And then at the end, we'll attempt to answer any questions that come in throughout the presentation. So just know that ideally, I'm covering most of the questions that I could anticipate, but we'll still have a period of time for questions. All right, next slide. To level set, for those who may be newer or are not as familiar with customized living, is a package of services that are that can address regularly scheduled health-related activities or support services for a person that's an adult, 18 years of age or older, and they must be residing in a qualified setting. And there's two levels of customized living. There's a non-24-hour customized living and then a 24-hour customized living. And there are additional requirements of what a person must meet to receive 24-hour customized living, which I'll identify in a couple slides later. When we talk about component services within customized living, we are referencing the distinct health-related and support services as part of the service. And we'll talk through each of those different component or areas and components that are available. And sometimes we will interchange customized living with assisted living. Generally, customized living is the Medicaid assisted living service, but for our Medicaid programs, BI, CADI, elderly waiver, we talk about this as customized living. So sometimes you'll see those interchanged, or you'll see some regulations that apply to customized living using the assisted living terminology. All right, thanks. Going to the next slide. Customized living is available for people on the BI, CADI, and elderly waiver programs, and they need to meet the specific age requirements for their waivers. So for EW 65 and older, BI and CADI, it's going to also be specific to the service of 18 and older, and then some settings are going to be limited to serving people who are 55 and older. The person must also have an assessed need for one of the regularly scheduled health-related and support services within customized living to be able to receive customized living, and then they need to be in one of the eligible locations. So there's going to need to eligible locations for customized living are going to have to ensure that the provider is eligible to meet and deliver the service, that the setting complies with the HCBS settings rule requirements, and any specific setting limitations that apply to BI and CADI. So there's several different layers that you're looking for, ensuring eligibility for a person to move into a location to ensure that there isn't payments can be made for services rendered. Next slide, please. So where are customized living and 24-hour customized living services delivered? There's two options. The first one is the predominant location on where services are delivered for customized living, and that's assisted living facilities. Those are regulated under Minnesota Statute Chapter 144G. This also includes assisted living facilities with dementia care. Then there's a special carve out that is created for really some public housing and affordable housing settings. There are approximately 50 of these throughout the entire state. And we have about 2,000 customized living settings in total. So it's a very, very small carve out. In those carve out settings, for customized living to be delivered, the provider still has to have a comprehensive home care license, and they have to be delivering that service in one of the 4 carve outs of affordable housing settings specified in Minnesota Statute 256S.20, subdivision 1. And there's additional requirements on top of that to ensure consumer protections for these exempt settings. Both of those types of locations must be enrolled with the Minnesota Department of Human Services. There's no way to get around that. So from a service provider's perspective and as a lead agency, what you will see is that the providers needing to work with both the Minnesota Department of Health, who oversees the assisted living license and the comprehensive home care license, and the Minnesota Department of Human Services, who's overseeing the Medicaid service delivery of customized living. So there's a partnership across both agencies and regulations that sit in parallel with one another. All right, next slide, please. So these are the component services of customized living. They're designed to be able to meet a variety of assessed needs for a person and are grouped into 6 categories: the activities of daily living, or ADL assistance, assistance with mental health, cognitive and behavioral concerns, health-related assistance, home management tasks, non-medical transportation, and socialization. So those are the 6 categories which contain subcomponent or sub-tasks or component services that can be performed within customized living. Our CBSM page outlines the different components that can be performed within those categories. And then we have also developed a resource page that gives additional details about what is included within each of those components and not included within the components. That used to be a PDF that has now been built into a web page. So if you're familiar with some of our older tools, the policy requirements have not changed. We just have changed the medium in which they are presented. It provides additional usability, readability, and it can also improve the efficiency in which we could change or tweak language to ensure we're addressing any confusion or clarifications. Making sure I got covering all my notes. All right, next slide, please. So earlier I referenced that there are specific criteria a person must meet to receive 24-hour customized living services. And this slide is detailing them out. So I do apologize that this slide is, the font is much, much smaller, but I didn't want to break out this content into 2 slides and make it harder to use as a reference point. This is contained in our CBSM So a person to receive 24-hour emergency assistance needs to meet one of these 4 criteria to be eligible for 24-hour CL. They may meet eligibility for multiple, but at minimum one of them. So the first one is that the person is assessed to need one of the following requirements: cognitive or behavioral interventions. The second is clinical monitoring with special treatment. Third is assessed as dependent in one of the following activities of daily living: toileting, positioning, or transferring. Number 4 is they have to have all of the following assessed needs: a dependency in at least 3 of the following ADLs: bathing, dressing, grooming, walking, or eating. And with eating, there's a specific score requirement of 3 or greater. Medication management, and then needs to have at least 50 hours of direct services per month. And the lead agency must approve these 50 hours of direct services for the individual in the 24-hour customized living service plan. Each of these needs must be assessed and documented in the person support plan by the lead agency. This is not determined by the service provider, but by the lead agency. And we can go to the next slide. So a couple things that are not covered by customized living or 24-hour customized living include room and board, transportation to healthcare services that are available through medical assistance or state plan services, also MNET, or we'll sometimes reference this as MNET. These are available through that benefit and not intended and cannot be used with waiver dollars. That would be duplication of services. 24-hour customized living and customized living services cannot incorporate socialization in the person's plan that is diversionary or recreational in nature. And then a person who receives CL or 24-hour CL cannot also receive chore, homemaker, or respite as separate services. These are included in the service rate already. It would be duplicative or non-compliant with a service option such as respite. Next slide, please. So kind of in parallel to the service limitations, there are provider practices that are prohibited. These are often questions that we receive based on some private pay practices or follow-up questions based on inputs that are allowable or not allowable within the component services. So for all of our Medicaid services, providers cannot request supplemental payment for covered services. The providers have to accept the MA enrolled, or as an MA enrolled provider, they have to accept the MA payment as payment in full, so the waiver payment as payment in full. They cannot require that the person or their family pay additional charges or fees as a condition of their residency, being in that assisted living facility. People who are living in customized living settings are afforded all of the same protections within landlord-tenant law and cannot be evicted without due process. And the assisted living licensing rules require information when a person, I have a typo here, I apologize that, requires information be presented to the person on how they can be discharged, transferred, or have services terminated. So many of the changes that were implemented during the assisted living licensure implementation in August of 2021 were around these requirements about when a person can move within a setting, have services terminated or changed, and be discharged. And the landlord-tenant law and protections on eviction have always been contained within the regulations for customized living and remain in place. Next slide, please. So the next section of the material that I'll be covering today is setting limitations that are specific to the BI and CADI waiver for the customized living services. These do not apply to the elderly waiver program. The BI and CADI waiver has 3 setting limitations, and we do communicate these within our CBSM manual, and we are looking at ways to revise our manual page to make these stand out in a more explicit way. So those are still something that we're actively working on, but the policies will be the same today that we cover. There's a location limitation, a size limitation, and an age limitation. And the next few slides that I'll walk through, I'll take each one of these individually and talk about how they align with one another. Next slide, please. So first, we'll talk about the location limitation. So customized living settings that have been developed or operational after May 1st of 2001 will have location limitations. There are two location limitations that prohibit BI and CADI CL service delivery. The first one is settings that are located on the grounds of or adjacent to an institution, and then settings that are co-located or next to one another that are operated by the same provider. So these limitations would apply when the customized living setting was developed after May 1st, 2001. There are exceptions to these limitations. They apply when the customized living setting was developed before May 1st, 2001, and that those settings have continuously delivered customized living services at that location. These are setting-specific location limitations. They do not apply to every single provider. So a provider, I'll state that again. These are setting-specific limitations. A provider may have multiple service locations that have different setting limitations apply. We are working on publishing a list of settings that are connected to institutions, so they're on the grounds of or adjacent to the institution. These are settings that had to go through additional scrutiny, so a review through the HCBS settings rule called heightened scrutiny. And once CMS has completed their review, we'll be able to publish that list. That list will represent all of the settings that had on-site visits through the HCBS settings rule work, which is hyperlinked here in our presentation that was sent out. And then customized living settings developed before May 1st, 2001 and have continuously delivered CL services could be co-located as well. And then co-located settings that went through the HCBS settings rule attestation process in 2017, we are allowing to be able to continue and ensuring that new developments that are occurring are following these location limitations. So if you're thinking about some existing customized living settings that you know that have been co-located on the ground that are next to one another, operated by the same provider, we do have the ability within our policies to ensure that they are grandfathered into our historical service delivery system and ensure that new service settings that are developed are complying with the location limitation. I've used institution several different times within this slide. When I am saying that when I'm referencing our hospitals, nursing homes, Institute for Mental Diseases or IMDs, or intermediate care facilities for people with developmental disabilities or ICFDD. Next slide, please. So that was the first cut when you're looking at customized living settings and reviewing the setting limitations. Then you want to look at the size limitation. We're using kind of the same dates as the location limitation. A customized living setting developed and operational between May 2nd, 2001 and January 10th, 2021 will have a size limitation. If that service setting serves people younger than 55 on the BI and CADI waiver. The size limitation means that the CL setting can serve no more than 4 people who are unrelated to the principal care provider. And so you might be thinking, okay, what options are available for a customized living setting that serves more than 4 people? The lead agency can complete a CL size exception through completion of the DHS form 7759 B as in Bradley. And then DHS, as we review those size exception requests, we can't approve any CL size exception requests when more than 25% of the units in that building are occupied by people on a disability waiver. That's regardless of age when we are calculating the 25%. As an example, if the building has 20 units and 10 of them are occupied by people who are in BI and CADI, and that size exception would be indicating that there's 50% of the units in the building that are occupied by people on the disability waiver, and that size exception could not be approved. We do have additional details that are outlined in the customized living policy manual in the size limitations section that walks through the different criteria that we are reviewing to ensure that the size exception criteria are being met. We often get asked, how do I find a list of settings that the CL size limitation applies to? We unfortunately do not have a list of settings impacted by the size limitation policy. The size limitation policy has been in place since May 1st of 2001, and over that period of time, we've had providers open and close locations, transfer locations, and different providers do change of ownerships at existing locations. We are unfortunately unable to go back in time and work through all of those different types of changes to have a comprehensive list of settings that have a size limitation policy. So as you're making referrals for the service to those locations, you'll be communicating with the provider and reviewing these service policy requirements, and able to review the MDH licensing lookup will have the licensing capacity. They do identify the number of beds that are licensed as an assisted living facility, and the provider is responsible for complying with these policies as well, and therefore need to provide accurate information to you as a lead agency to comply with these service limitations. Next slide, please. So the third setting limitation for customized living is the age limitation. A customized living setting that is operational on or after January 11th, 2021 is limited to serving people only 55 years of age or older on the BI and CADI waiver. There is no exception to this age limitation, and attempts to enter service authorizations in an MMIS for settings limited to serving people 55 and older should populate an MMIS service authorization edit, the 424 age limitation edit. When reviewing that edit text in MMIS, you would see that it explicitly states not to force the edit for customized living. And so this is the kind of the final trigger of saying, no, this is not an eligible location for a person who is younger than 55 to receive customized living services. To assist in identifying settings that are limited to serving people 55 and older, we have published a list of those settings. It is updated once a month, usually at the beginning of the month. And it's important to know that this is just a point in time resource. It is not the only available location to identify if the setting is enrolled and limited to serving people 55 and older. We also need to recognize that because it's a point in time resource, settings that are currently in the process of enrollment are not going to be captured in that list because it can't get updated in real time. And that if a current customized living setting is moving to a new location, that's a new setting, and it's going to be impacted by the age limitation policy because it's going to be a new setting operational on or after January 11th, 2021. We also will not have change of ownerships that are going through the enrollment process as well. However, a change of ownership is not moving a location. It would be the same location, and therefore the setting limitations are not going to change that are applying to that location. And then it's important to note that if there are any settings that are not enrolled with DHS, those settings are ineligible to receive customized living authorizations. So just wanted to reiterate that these limitations are specific to each setting. One provider may have 4, 5, 6 different settings, each having a different setting limitation applied to them. All right, next slide, please. Because the list of settings that are limited to serving people 55 and older is, like I said, a point in time resource, there are other ways to verify if a provider is enrolled or to verify if the setting is limited to people 55 years of age and older. To verify if a setting is enrolled, you can review the Minnesota Help.info webpage. It's also available within the provider's record within MMIS, or the Medicaid Management Information System. When you are reviewing MMIS as a lead agency, you can see the provider's license credentials on the PLIC screen. And you're looking for credentials of L7, L8, or L9, which are those credentials limited to serving people 55 and older. And then the other assisted living, or excuse me, the other customized living enrollment license credentials are AL, DE, and CE, and those may be able to support people who are younger than 55. Now, we recognize that not all case managers have access to MMIS. And so as you're developing resources or supports for case managers, just know that there are the different ways that we can verify locations that may or may not be able to support people who are younger than 55 in a customized living setting. Next slide, please. And then there's one final setting limitation or a setting specific policy that is newer. And that is something that the 2021 Minnesota legislature passed. They created a customized living moratorium affecting new customized living settings serving 4 or fewer people in single family homes. That has been in place since July 1st of 2021. And again, that moratorium is prohibiting the department, the Minnesota Department of Human Services, from enrolling a new customized living setting serving 4 or fewer people in a single family home. Next slide, please. This is a summary of the setting limitations that are specific to each of the slides before, just stating them in a different way. So the first one is flipping, instead of just thinking about it in a location, size, or age limitation frame of reference, is identifying how a setting that's developed before May 1st 2001 is going to be impacted. So a setting that's developed before May 1st, 2001, the location, size, and age limitation are not applying. Customized living settings operational on or after May 1st, 2001, and on or before January 10th, 2021, the location limitation will apply and the size limitation will apply. And then CL settings operational on or after January 11th, 2021, the setting location and age limitation will apply. And then reiterating the CL moratorium. Next slide is a list of the disability waiver rate system, rate setting requirements, and resources that are available to assist in that process. I do not have anybody here with me from the fiscal policy team. If there are rate questions, I will have to direct you to submit those to the fiscal policy queue. But I wanted to make sure within the presentation and the material that you'd have available thereafter that this is kind of contained all together. So again, the intent of covering this material is to reiterate what the customized living service is, what it can cover, some of the limitations that are specific to the service settings, and then I will move to the next slide and answer some questions, hopefully a few verbally. And then depending on the questions that are there, I may need to answer them in a written form, and I'll try to answer some of those today as well. So 1 second while I look at the chat.
I think there are 4 questions in there, Stephen, from what I can tell.
All right, thank you, Chad. So
Let me know if you.
Yeah, so the first question is asking about examples of socialization that would be included or not included within 24-hour. And so the time that's incorporated within the socialization activities needs to be specific to the person's assessed needs and goals, not just access to programs that the assisted living facility has available to them. So it's always tying back to what is the person's needs and supports, how are they accessing their community, and having their individual preferences addressed. We have one question. The next question is that we are finding some customized living providers are not aware of the moratorium related to the size limitation. We have found 5 different providers unaware within the last month. Has DHS considered new communication with providers around these setting limitations? Providers are, every new customized living setting has to be enrolled. Actually, all customized living settings have to be enrolled, and as part of their enrollment, they are attesting that they know that these are the policy requirements. We have and are considering and exploring additional ways to provide customized living training opportunities for providers and lead agencies beyond just this DSD quarterly update meeting. So we will take that into advisement, and we do provide technical assistance to customized living providers directly and have consistently communicated the same policy limitations that we discussed today. The next question does have some similar overlap to the last question. What is being done to ensure providers understand the service limitation for CADI and BI? Providers are not aware of the service limitations, and they will state that they'll accept the person even when they are under 55 and make arrangements to move forward. Lead agencies have to have processes in place to catch these before a service agreement is entered. Where do we report providers who are not following these requirements? So there's several different questions kind of layered in there. The providers are required to deliver services that comply with our program requirements. If they are fraudulently delivering services or misrepresenting the services that they are able to provide to a person, you can make referrals to Mark. You can make referrals to the licensor. If you're concerned about inappropriate billing and services rendered, you can always make a service referral. Providers, when making, as a lead agency, when you're making a referral for customized living services, the part of the informed choice process for the person is communicating how the service limitations are going to impact where a person might choose to live. So knowing that a service provider is saying that they have an opening, but that opening is limited to serving people 55 and older, that would not be a real choice for a person. That's not an eligible location that would be able to move to. A provider saying that they can do that and not is they're communicating services that they're not eligible to render to a person younger than 55 at a setting limited to 55 and older. And that is ideally being addressed before service authorization is occurring. Our system controls to ensure program integrity and Medicaid fiscal integrity are done kind of on the backside of it, on the service authorization to prohibit that authorization. And we're also going to be having a claims edit in place to prohibit any payments that slip through our service authorization prohibitions. And so it's important to ensure that during the informed choice process and the service referral process, you're addressing what is a real choice for a person to be able to receive, and ensuring that the provider is giving you accurate information. Okay. The next question is about where should providers be directed who are not understanding their limitations. We have case managers report to us that providers do not understand what they are communicating and sometimes move people from one setting to another without telling their case manager, and have to move people from an eligible setting to and are moving people from an eligible setting to an ineligible setting. You can direct service providers to the department to submit questions through the DSD contact form. It's also important as lead agency that you're sharing the same information with them as well, of if you're moving a setting to a new address, that is going to impact the existing service options that are available for a person, and we can't retroactively authorize services that are ineligible. The last question I see right now is, can you repeat where to find a list of providers and their size requirements? We do not have a list of providers that the size limitation applies to, but you can use the Minnesota Department of Health provider lookup, or the licensing lookup for assisted living facilities. And in that lookup, they identify the number of licensed beds at the setting. So you'd be able to see the approved number of like the beds that are licensed at that location. And we tie the beds licensed to the units is a rudimentary parallel. And I see that in the chat, a link to, I believe our CBSM page was also provided. All right, that looks like the questions that are submitted in the chat. I will stay on for a few other minutes, kind of in the background, while we move to the next topic to see if any others come through, and I'll submit those, I'll respond to those questions in writing. But I appreciate everybody's time today, and I do want to recognize that customized living is probably one of our more complicated services. There's a lot of different service layers and policy layers within it. So I do appreciate everybody asking the questions and working through some of these difficult changes. So thank you for your time today.
Thank you, Stephen, for the presentation. Next up, we have DHS announcements, and my colleague Lisa Nolan, RRS for regions 5, 7E, and 7W. So the middle portion of the state will be covering that. So you're on, Lisa.
Thanks, Chad. Appreciate it. Good afternoon, everybody. Lisa Nolan here, Regional Resource Specialist in the Central Minnesota area. We're going to just move through some DHS announcements real quickly. Wanted to touch on the Federal Centers for Medicare and Medicaid Services, or CMS, approved DHS application for renewal of the DD waiver program. The DD waiver plan is effective from July 1st of 2022 through June 30th of 2027. So the next 3 slides that we review will show the changes that have been implemented since the renewal of the DD waiver. So DHS received federal approval from CMS to add ICS to the CAC and DD waivers effective January 1st of 2023. And this approval does not affect people on BI and CADI waivers because ICS is already available under BI and CADI waivers. Lead agency staff can authorize ICS for people in approved and enrolled settings effective January 1st of 2023. And for a list of the approved and enrolled ICS settings, you need to refer to the resource ICS settings link on the bottom of the slide. DHS will also begin a rolling implementation of ICS to support an orderly transition for people on CAC and DD waivers. So please review the December 30th e-list and the ICS CBSM page that was linked on the slide for more details about that implementation timelines. Then effective on January 1 of 2023, the following changes have been made to night supervision. So DHS has removed the limitation of awake staffing to cover asleep and awake staffing, and added a limitation that the service cannot be used as a preventative or assumptive safety measure. Additionally, DHS has added a limitation to 24-hour emergency assistance that does not allow staff to sleep in the person's or family's home to ensure that there is no duplication between services. So if you're supporting a person who is using 24-hour emergency assistance for a sleep overnight support, you need to see the implementation instruction on the linked e-list here. So we're going to look at related individuals are now able to provide individualized home supports with training. So when a person is authorized to receive individual home supports with training, they may make an informed choice to have a related individual provide the service when complying with the policy requirements that are found in the CBSM page. Paying relatives and legally responsive individuals. You can see that link on the slide. So the lead agency must update the person's support plan before the related individual can provide individualized home supports with training. And this update may occur at the person's annual reassessment or sooner if desired. The lead agency must document the person's informed choice of whom will deliver the service and how the related individual meets qualifications. Okay, so next we're going to talk about some MinChoices updates. So the MinChoice revision is on track to launch on March 31st, 2023, with DHS deciding to implement a phased launch. This will include an extension of the transition period to finish work in the existing systems to August 31st of 2023. And then DHS will be providing a transition document that provides further instructions and best practices for lead agencies and their transition to the new application. Lead agencies will have access to the system April 3rd of 2023. And for additional information regarding the launch schedule, please see the February 16th e-list. DHS continues to host launching webinars to help prepare agencies for the revised MinChoice application. And these webinars have been recorded and are available for reference on the DSD training and news and information page, which we have also linked at the end of this presentation. So DHS is continuing to work with CMS on preparing a formal submission of state planned amendments for CFSS. So DHS cannot provide a specific launch date for CFSS until CMS approves the state plan amendment. But they're going to continue to provide updates as more information becomes available. And DHS will announce a CFSS launch date at least 90 days before that point. So for more information on this, please visit the web pages linked on the slide, or if you have specific questions that are related to CFSS, you can send an email to dhs.cfss@state.mn.us. Okay, so the next we're going to talk about as the DSD Resource Center is now called the Service Agreement and Screening Document Support Team, or SASD. The new name better reflects the specific area of work supported by the SASD support team. So the Service Agreement and Screening Doc Support Team is a help desk that provides technical assistance to lead agencies and DHS staff for MMIS, specifically related to the service agreements and screening documents. Lead agencies should contact the SASD support team with MMIS related questions using the Secure Service Agreement and Screening Document Team Portal, which is the DHS 3754 form. Okay. So just going to update here on DHS created a new online portal for lead agencies to securely submit environmental accessibility and adaptation, or EAA, exception requests. This change eliminates the need to use a secure fax for this process. So you're going to be able to find more information on this topic or this exception criteria on the EAA CBSM page that's also linked on this slide. We wanted to review an E-list clarification on the additional exception to the corporate foster care licensing moratorium. So this E-list provided a policy clarification about one of the setting eligibility criteria needed for the moratorium exception. A CL setting license for more than 4 people could meet the setting eligibility criteria if they are serving 4 or fewer people on the BI or CADI waivers and meet the other 2 criteria. So for example, setting is a single family home and was operational on or before June 30th of 2021. And just to note that the customized living setting criteria are only part of the eligibility criteria needed for the moratorium exception. So for a complete list of all the moratorium exception criteria, you can visit the CBSM moratorium page that is also listed on the slide. All right. Going to touch here on the unitary residency and financial responsibility statute. It was revised during the 2022 legislature. We encourage you to see page 36 of the Minnesota Healthcare Programs Eligibility Policy Manual, where it identifies that integrated community supports and day support services have been added as excluded time. So please see that link. All right. We also wanted to make you aware that the microgrant program window is now open. The application review and grant award process may take up to about 45 days to complete. Applications will be accepted from the person, their support staff, family, and friends, and only 1 microgrant per year may be awarded to a person. So if you'd like more information, you may contact the ARC or the microgrants at arcminnesota.org or at 952-920-0855 with questions. We also wanted to make you aware of a state grant that was awarded to 12 organizations to support technology that can help people keep medical appointments, connect at home, and community-based services and combat social isolation. The grant recipients are in the linked news release highlighted, and the amount received and how much they will use technology to improve people's ability to live independently. Another update is DHS has added links to translated versions of life sharing in the CBSM pages that are linked on the slide. It's now available in the following languages: Spanish, Hmong, Somali, Russian, and Karen. And the final update here is just that here's a DSD e-list that references the information that Carly went over in the beginning of our presentation. So please reference the e-list linked on the bottom of your screen for further information. All right, and then I am going to turn it over to my coworker, Cassie, to introduce herself. Cassie?
Thank you, Lisa. Good afternoon, everyone. I am Cassie Tulp. I'm a regional resource specialist here in the Metro, and I office out of South St. Paul. I'm going to go ahead and get started here with some COVID-19 updates and resources for everyone. Just want to touch base on the federal public health emergency renewal. If you want to go to the next slide there, Kyle, thank you. On January 11th, 2023, the U.S. Department of Health and Human Services extended the federal COVID-19 public health emergency for an additional 90 days. Following this announcement on January 30th, it did announce it plans to end the emergency on May 11th of 2023. DHS is carefully planning for the end of the public health emergency and how it will impact people served by the LTSS program. The Aging and Adult Services and Disability Services divisions will continue to keep lead agencies apprised of coming changes and provide direction for the wind down of the affected COVID-19 waivers at the end of March. The next few slides will review the COVID waivers that are attached to the U.S. Department of Health and Human Services COVID-19 public health emergency. So the following COVID-19 waivers will remain in effect for up to 6 months after the end of the public health emergency. CB15, which allows for long-term services and support assessments and reassessments to be conducted remotely, as well as allowing case management visits to be conducted remotely. And then CB44, which is allowing remote delivery of adult day services. Because the federal public health emergency has not ended yet, end dates for these COVID waivers have not yet been determined. The following COVID-19 waiver remains in effect until further notice from DHS, which is CB17, the Preventing Termination of Eligibility in LTSS programs. And DHS will communicate more about this change in the transition timeline. At the end of the federal public health emergency, the following waivers will end. The allowance of parents of minors and spouses to provide personal care assistance services, or PCA, as well as CB24, which is allowing phone and video visits in place of in-person contact for child welfare, mental health, and vulnerable adult / developmental disability targeted case management services. So parents of minors and spouses who have been providing PCA services during the COVID-19 emergency should work with their PCA agency and or their county, tribal government, or managed care organization to develop an alternative plan for provision of services in anticipation of that amendment ending. All right, at the start of the public health emergency, DHS published a resource with scenarios about how to maintain a person's HCBS eligibility during this period. DHS has updated the frequently asked questions about maintaining HCBS eligibility under COVID-19 requirements webpage. And DHS has made updates to the following sections. Scenario 3, changes to level of care or service needs. Scenario 6, incarceration. And Scenario 9, other residential treatment settings. Now going to highlight some upcoming training sessions and webinars. The Building Your Skills, Developing a Support Plan webinar training series will be returning in June. Webinars will be held on the last Wednesday of each month from June to September. These sessions are now available to sign up via TrainLink. Between now and June, DHS will create online self-paced training modules for support planning from the 2022 Building Your Skills webinars. And details about these online modules will be included in an e-list going out during the first 6 months of 2023. Additionally, DHS will send monthly e-lists that identify current TrainLink modules recommended for new and experienced assessors, case managers, care coordinators, lead workers, and supervisors. A little bit about the Transition Services Community of Practice. Effective January 1st of 2023, RSC policy oversight has been moved to the Moving Home Minnesota team. They will continue with the joint community of practice between Moving Home Minnesota and RSC providers and lead agency representatives, now called the Transition Services Community of Practice. This is a group of lead agency and private provider staff who can come together to discuss best practices, receive updates, and provide feedback on policies. It's an opportunity to share resources and community with each other. Please note that meetings this year will be hybrid. And Moving Home Minnesota has a goal to offer 4 total community of practice meetings in 2023, with the first meeting being in the metro area. Moving Home Minnesota would like to offer meetings throughout greater Minnesota. So if your lead agency, tribal nation, or organization is interested in hosting a meeting, please contact us at movinghomemn.mfp@state.mn.us, which is linked here on the slide. And then the DSD training news and information page is where you'll find the latest trainings and webinars offered through our division. You will also find a link to the DSD training archive page that lists all past DSD trainings and handouts that we recorded. We recommend you bookmark this page just to stay up to date on the most current trainings. And lastly here, sorry, my screen is lagging a little. We wanted to make you aware of some self-paced trainings that are available through TrainLink. You can go ahead and review these on the slide, and some good ones on Rule 185 and CFSS for lead agencies. Next section here will provide you with helpful resources that may be helpful to you and the people you support. So we want to remind you that DSD has a website that contains information and resources related to the direct care workforce shortage. It provides information such as state-sponsored work group and provider resources. We do encourage you to take a look at this page and keep updated regarding current efforts to address the workforce shortage. And we did include some links in the PowerPoint here for some additional resources regarding workforce shortage that we have discussed in previous DSD updates. The DSD contact form also provides a consistent way for people to submit questions and get technical assistance for DSD related topics. This form was recently updated as well to hopefully be more helpful for lead agencies, case managers, assessors, everyone using it. And last but not least, here are some of our foundational resources for communication and policy references for DHS. We did recently add a link for the Case Manager and Care Coordinator Toolkit, which we highly encourage you to go ahead and take a look at. All right. And then thank you all for joining us. Yep.
Before we end here, we just had Maria Trueblood from our waiver policy and compliance team join regarding night supervision question. So I'm going to go ahead and hand over to Maria.
Great.
Maria, would you like me to state the question?
Yeah, thank you, Felicia.
Sure. So the question that came in says, please describe some examples of preventative or assumptive services under night supervision. One example is the potential for a nighttime seizure. Is nighttime supervision for seizures, whether asleep or awake, considered assumptive and therefore not allowed?
Yeah, so I just want to say, first of all, that we're not going to deal with like hypothetical cases. So if you have an actual situation, please send it in to us and we can respond better that way. I would say the key word in that question is potential. That implies that there hasn't been a seizure overnight or that the person isn't having any overnight supports. So that's the idea. Like, we couldn't just put something in place because we are concerned it could happen. There has to actually be that overnight need. And that same thing goes for maybe you are assessed to need a support. So if it doesn't happen overnight, why would we put a support in place for it? Or maybe the person gets up overnight, but it's with needs that they can already do themselves. So like if somebody's not needing support with like toileting, they would not need, you know, help with that. We wouldn't put in extended PCA or night supervision to help the person with that, even if they're getting up overnight. It really goes back to having an assessed need for assistance and supervision in the implementation of the positive support programming and transition plan. So that is not just the presence of behaviors. They actually have to have a positive support and transition plan available. They have to have a reinforcement of skill developments. So it's something that has happened. And it could be the skill development of how do you wake up and you can't put yourself back to sleep. You know, maybe there's some insomnia happening and they need to have that routine. You know, I don't know every single person who has overnight needs. So that's something that there may be other things happening there, or assistance with activities of daily living. And I know that one gets complicated really fast because we have extended PCA, and then assistance with instrumental activities of daily living. So it really is meant to be a fairly comprehensive service for people who need an overnight assistance. I think that answered the question, but I just going to take a minute and let people think about it.
Thanks so much, Maria, for hopping on here.
All right. Well, thank you for joining us today, everyone. If you do have additional questions about the information contained in the presentation, you can submit them using the DSD contact form. And thanks again, and have a great day, everyone.